Hello, everybody out there in YouTube land and in Spotify and podcast universe. My name is Dr. Craig Selinger. I am the host of the Injury Podcast. And today we have a great show and an awesome panel. We're going to talk about something that's very scary for people. It's surgery, specifically spine surgery. Many people that are in accidents suffer with spinal complaints, and they're very scared about making the decision whether or not to have surgery. Our goal today is to give you a little bit more information, educate you so you could make a better decision and feel more confident about the road to your recovery. But first, let me introduce our panel. Today we have with us Jen Nestler. How you doing, Jen?
Hi, everyone. Thank you so much, Doc, for having me back. I'm Jen, your MRI Girl with Windsor Imaging.
Yeah, so this is number 2,
Yes, it
right?
is.
Awesome. She's been on the podcast twice. Great. Great to have you. And then we have Danielle Kushel.
Hi, how you doing?
Good. How you doing today?
I'm doing great. Happy to be here.
Awesome. Awesome. Great.
Long time watcher, never a visitor.
Great. And we also have a pleasure of having board certified spine surgeon, Dr. Alam. Nice to have you today.
Thank you. Thank you for having me, Doc. I appreciate it.
Yeah, great. So what I want to talk about first is something that people come to my office, I'm sure yours too, and when they have an accident, a new injury, it's so difficult to make the decision to have surgery or not. When they haven't had time really to process it. They haven't lived with it. They don't know the full effects of it. But when they have an old injury, a chronic injury, a back injury, they live through it. I kind of, I make the analogy of a chronic back injury is like having a bad roommate. One, they keep you up at night, all night. 2, they are always coming by when you don't want them. And 3, when you think they're gone, they find a way to come back in with a whole new set of problems and drama. So we can make those decisions because we want that pain gone. We want that roommate gone. But a new injury, we haven't had time to process it. So what do you say to patients to help explain or to educate them about their needs for surgery when it's a newer accident?
First of all, thanks for having me. Milad Alam, I'm an orthopedic spine surgeon, so I do take care of a lot of chronic degenerative issues, the chronic roommate.
Yes.
And also a lot of acute injuries where patients have had a slip and fall, or they've been in a car accident, or fall off of a ladder, or a work-related type injury. I think the difference between the two is that in a chronic setting, patients have learned to adapt. They are doing things that helps them avoid those pain-provoking stimuli, as opposed to in an acute setting, patients are just dumbfounded. You know, all of a sudden they were pretty healthy. They were playing with their kids. They were going to the gym, and now the pain is limiting them, and they have not been able to adapt to a new lifestyle to coexist with that pain. So again, if you do have a roommate that you don't like very much, you know he's going to come in late on Saturday nights. You make sure your door is locked.
Exactly.
You know, your light is off so he's not bothering you. But if you're just watching TV, you're not expecting somebody to come in and they just barge into your apartment, that's a bigger problem.
Yeah, it is. It is. It's a surprise. And that's kind of why I like that analogy, because people, they're at a point a lot of times when I see them, if I know people that have had, let's say, sciatica for 3-4 years, they're so tired of it. They're ready for that to be gone.
Right.
And with the newer accidents, they just don't know. Well, hey, maybe in a month it'll get better. So I think for a lot of people watching out there and listening that have been in an injury, have had something injury related, they need to understand what kind of questions should I ask? What are the signs and symptoms? And Also, I hate to say this, Doc, but a lot of people think if they're going to have back surgery, they're going to be worse.
Right.
There's a myth out there that my back's going to be worse. So we need to speak to that, and we need to prepare the patient. I feel if they're more prepared, they're going to make a better decision that they're going to feel comfortable with. They're not going to be having those should I, could have, maybe I did the wrong thing kind of conversations, which is bad. So why don't you speak to that a little bit?
So I think whether we're talking about an acute setting or a chronic setting, what's important to understand is that surgery, even the decision of surgery, has to be brought up when you have, or the patient has exhausted every other conservative measure. So in an acute setting, a lot of times the soft tissue, the ligaments, the tendons, everything is inflamed. So during that time period, a lot of times we recommend chiropractic treatment, physical therapy, just rehab, and buying some time to let things calm down. A lot of times, if that first phase, they don't respond to that, their neck pain or back pain is not getting any better, then we go to the second stage, which is typically relying on some injections. Injections are a lot of times steroids given specifically to the site of the injury, and they can both be therapeutic and diagnostic, meaning that not only will you get some relief from that injection, but also it's diagnostic. So if the relief lasts not so long, at least me as a spine surgeon, I know that we were in the correct spot. So when it comes down to something surgical, we go after that level. So last but not least is surgery. And unfortunately, as you said, spine surgery does not have a very good reputation. And that's for multiple reasons that I can, I'm sure we'll get into. But, when it comes down to spine surgery, first of all, again, the patient should have exhausted everything else. And one thing we have learned over the past 2 decades is that less is more. It used to be that most patients would get a big whack in the back, a multi-level decompressions or multi-level fusion surgery, and we have learned that those patients don't do as well. So there has been a paradigm shift in spine surgical world where we focus, target exactly where the problem is, and we do smaller surgeries through smaller incisions. So minimally invasive spine surgery is something that we all employ, a lot of the newer generation of spine surgeons, I would say, employ to minimize the complication rates post-op, rate of infection, rate of post-op pain, not being able to go back to work. All of that improves. Opioid dependence, all of that improves when you have smaller incisions, doing your decompression or even fusion surgery with screws and rods through smaller incisions. Those patients tend to do better. I jokingly say a lot of my patients are not DTF. They're
Right.
not down to fuse.
They're
Nobody,
not. Oh, that's hilarious.
most patients, because I call the F word, they have had such a negative perception of fusion surgery. And what I want people to understand is that fusion is really our last resort. A lot of times, even if you go down the road of surgery, we use minimally invasive techniques, incisions that are about 1 centimeter or 1.5 centimeters to do a decompression, meaning clean things out around the nerves or clean the herniated disc out. And or if they need the disc completely gone, we rely on disc replacement surgery as opposed to fusion surgery, which we can expand on the advantages of that versus a fusion surgery. I think that there's multiple reasons why patients have a bad perception of spine surgery, and I think what I want to communicate is that things have changed and are changing. So, and patients do have better outcomes now.
Mm-hmm.
That is true. Actually, so I wanted to ask you, so who would be a good surgical candidate for you? And if they're not a good surgical candidate, what are some surgical options that maybe?
So again, it has to be a patient that has exhausted conservative measures. And when it comes down to surgery, the better you are pre-op, the better you do post-op, right? And I would say the surgical candidates that are more informed, they do better. Surgeries that rely on smaller decompression or a disc replacement where the patient is not so limited post-op, Those patients tend to do better. There are some patients who are just not good candidates for surgery because of age, because of bone quality, because of their nutritional status. And those are patients that I'm, again, a huge advocate of continuing with conservative measures, rehabilitation, core strengthening, massages, and also relying on injections a couple of times a year is the way to go.
All right. Thank you.
Good. So, in terms of, I know there's some new, you talked about fusions. Can you explain a little bit about a fusion? And I know there's other type of common surgical techniques that you do today, like disc replacements and stuff. I know we have some models here.
Yeah, so this is nice that we have actually some models. So this is kind of a typical unit of, let's say, a lumbar spine or cervical spine. So typically you have bone, right? These are kind of, I call them the Jenga pieces that are forming your back spine. And then you have the little cushions in between them called the discs. What happens over time, inevitably, is that we start wearing out these discs in between the pieces of bone, and also these joints in the back of the spine called the facet joints. And once that happens, once things start wearing out, you're looking at this other image where there's no disc left. The nerves that are exiting in between pieces of bone are getting squished. So there are different ways of treating this. If we can, or again, it really depends patient by patient and looking at the MRI, if we can just go in through smaller incisions and clean things out around these nerves that are getting pinched, that's obviously the preferred choice. However, if we really need to place a spacer where the disc used to be, look at the difference in the height between these two guys. You could actually see one of them has the disc in it and the other one doesn't have the disc in it. So a lot of times we rely on placing a spacer between these two pieces of bone, and that spacer can be either a static titanium spacer or a medical grade plastic, and that by definition means a fusion. Or more often than not, we can actually try to place a mobile or an articulating spacer, and that's an artificial disc that can be done in the neck or in the lumbar spine. The advantage of having an artificial disc is that you, first of all, maintain motion at that level. You don't have to lose movement at that level. Secondarily, when you fuse a level, you're putting more pressure on the adjacent segment. By not doing that and putting an artificial disc, you're reducing that risk. You're reducing the amount of pressure on the adjacent segment. We have learned, and we know people who actually have a fusion have about 30% chance of needing fusion done at the adjacent segment, at the level above or below, within 10 years. So having an artificial disc allows you to avoid that in the long run. In the short run, the advantage of an artificial disc is that you're not really restricted. I do a lot of these surgeries as an outpatient. Patient goes home the same day. Let's say they have a cervical or neck disc replacement. If the case is done on a Friday, I let them drive by Monday. I let them go back to work by Monday. They don't really have to wear a neck brace. It's just for comfort, I give it to them. So these are kind of the short-term and the long-term advantages of a disc replacement versus a fusion. Obviously, if we can just get away by cleaning things out without any sort of an implant, that's what we do first. But if it comes down to doing something surgically where we have to place a spacer in between the pieces of bone, again, there's a static option and an artificial disc option. The artificial disc option is obviously preferred. Artificial disc replacements have been in the U.S. for about 30 years with a pretty good track record. They started in France and Italy about 14 years before they even started in the U.S. But I think there is a pretty good track record in the U.S. for these. And even though it was initially reserved for patients under the age 50, we're really pushing the boundaries and indications that we're doing them on older patients with pretty good outcomes.
Great. Wow. Well, Danielle, I know that you're a personal injury attorney here in Palm Beach County locally, and you have many clients that are injured in either falls or car accidents. And what are some of the concerns or issues that your clients bring to you regarding orthopedist or surgery? and what has been your experience in how you help the patient kind of navigate through this very difficult time where they just had maybe a major accident, and within a short period of time, like what I said before, they have to make certain decisions.
Sure, sure. Well, thanks for having me. My law firm's Kushel Law Group in Boca Raton, and I help people all over South Florida. I've had a lot of clients who've gone through the disc replacement surgery, who've gone through even fusion. So I can definitely say that a lot of what he's saying with regards to the difference in the result and the the client's level of happiness with doing the procedure is night and day with these new advanced, minimally invasive procedures that they're doing. I think one of the bigger misconceptions that I come across is that we kind of touched on it, but everyone assumes surgery means fusion. You're going to look like Frankenstein. You're going to have hardware screws and like long bolts. And I think that is how it used to be. So it's a fair assumption. But there's a lot of misconceptions where people are Googling themselves or looking things up. What I do as an attorney, I think that a lot of attorneys can tend to be a little bit pushy when it comes to treatment, getting involved in this. My clients are on their own treatment journeys with the team. My job is to make sure that they have a great team behind them that is covering all the specialties, because it's a path from the beginning all the way, to a spine surgeon, for example. And really, rather than pushing someone to go do something or to someone, it's more about ensuring that they are getting in the hands of a doctor like Dr. Alam, for example, who is going to guide them and more importantly, answer a lot of their questions. I'm very often setting up another appointment even while the client's figuring out whether they want to do surgery. I'll ask doctors that I work with, can you have another appointment with them? Maybe their wife can join or something, and we can kind of clear the air about whatever questions. I mean, I've had clients who wanted to know specifically exactly what position they would physically be in during the surgery while they were under anesthesia and wouldn't know anyway. But, everyone's got their own concerns and anxieties about even just being put under for a procedure. So I think a lot of it is also regarding the post-op, lack of post-op, essentially. There really is, especially with these minimally invasive, not much that needs to be done afterwards. And so dispelling that, I think is important. It's not necessarily the lawyer's job to do that, but it is important that the lawyer's making sure they're working with a care team, a treatment team that understands the importance of discussing these misconceptions and clearing up any questions so they can decide if they want to do it based on their pain level. And that's how I approach it with my clients. Rather than being pushy or really getting involved in that discussion, I tell them at some point the pain is going to reach a point where it outweighs the fear and the anxieties. And the question isn't an indecisive process for you anymore. The pain speaks for it. The pain decides for you. And I think a lot lot think about that. I don't want to be in this pain anymore. Kick the roommate out.
Right.
Yes,
Right?
exactly.
Kick that roommate out.
Yeah.
I've used that analogy before.
If you don't mind, I'll follow up. I think you brought up two great points. Number one is that spine surgery is a lot. When you even talk about a disc replacement, a lot of patients ask, well, how is this done? Where is the incision? I mean, how are you getting to my neck? And when I tell them we're going from the front through a tiny incision, they're just shocked. Right? So I have 15 to 20 minutes. Sometimes when I'm lucky and I'm not behind in clinic, I have 30 minutes to explain all that to them. But I explain it to them. I explain the MRI. I review the MRI with them. I show them exactly what is done. I tell them about the surgery. I give them additional information. I say, please don't make a decision today. Come back, see me in 2 weeks. Please bring back your wife. Please bring back your kids or whoever is going to be with you through the process so you make an informed decision. I want my patients to feel empowered when that it is their decision. I call myself the waiter. I say, hey, these are the specials on the menu. This is what it is, and these are the options, and these are the risks. These are the benefits. And as to Danny's point, it gets to a point where the benefits outweigh the risk. The second point you brought up is, you say that, as an attorney, that you don't want to communicate with the patient as far as the post-op. But you, as an attorney, you have seen probably more than the patients. You have seen how patients do post-op or what the recovery process looks like. So a lot of times you guys can actually help the patient with that decision-making, but also, of course, not appear to be pushy because there's an ulterior motive in the back of their mind.
That's
you know?
actually one of the things that I find most helpful for people weighing this decision is I have in my network of clients who are like family to me, past clients, present clients, many people who not only had surgeries or went through this, but are so happy with their results that they would be more than happy to speak to someone else about it. And so, hearing someone on the other side of it who's already kicked the roommate out,
Right.
I imagine if it were me in that situation, it would really reassure me.
Yeah.
A lot.
So I've been lucky. Sorry, I've been lucky because my surgical scheduler had surgery with myself and my partner. So a lot of times when patients call to speak with her, she lets them know because she went through
experienced
that
it.
process as a patient who's doing very well. So it gives confidence to the patient. So I'm very lucky to have her.
Like she could vouch for you.
Right.
Everyone has an uncle that had surgery and it didn't go well.
Correct.
Everybody
Yes.
does
Right.
Yes.
for some reason.
So, wanted to talk to something about something that some of the people out there that are listening and watching the video might have questions. They might not go to the doctor. They might wait. Some people, because of insurance challenges or whatever, they might wait. What are some red flags that if people are experiencing out there listening that they need to get medical attention right away?
Yeah. So great question. So some of the red flags are, numbness that is not going away, weakness that is not going away. By going away, meaning that if you have, for example, you see that your foot is dragging, you're not able to lift up your ankle, that's an urgent matter. So, within the first 48 hours, I would say probably to seek attention. One thing that goes a lot of times unnoticed, and it can actually be a complete incidental finding, even in a spine surgeon's office, is cervical stenosis, pressure on the spinal cord that can happen from a disc herniation, whether it is acute or chronic. When there's pressure on the spinal cord, even if the patient doesn't have neck pain, they start developing some chronic disability, some chronic signs and symptoms. There are actually 3 of them to keep in mind. One of them, when you're looking at kind of spinal cord stenosis, one of them is gait and balance disturbance, meaning that patients feel wobbly. Patients feel like they're unsteady on their feet or going up and down the stairs. They have to hold on to a railing because otherwise they feel like they're going to fall. The second one is urinary frequency. The bladder is not able to empty out the urine. So what happens every time you go to the bathroom, you're not putting out all the urine that's sitting in the bladder. So you keep wanting to go to the bathroom. I mean, obviously there's other reasons for that as well. The third and the last one, which again, patients may not notice, hey, this may be coming from my neck, is dexterity issues. Issues with performing fine motor skills like writing, buttoning your shirt, putting on your earrings. Those are the 3 subtle things that we look at. And when patients complain about it, I quickly get a neck MRI to make sure I'm not missing a cervical spinal cord stenosis.
Right.
The one way to remember this is actually one of the first group of people who came to understand that and recognize that, hey, cervical stenosis can lead, for example, to dexterity issues, us using our fingers and hands, where the Japanese, they actually noticed that their grandparents or their parents who have been, using chopsticks to eat for decades, now all of a sudden they have a hard time using their chopsticks. So, in fact, there is a Japanese classification system for cervical stenosis or cervical myelopathy. So that's a good way of remembering, hey, if there's dexterity issues, they're dropping things that can open up jars. If they have balance issues or urinary frequency, look at their neck.
Right.
And
What about the numbness around the saddle area? Can you explain a little bit about that? Cauda equina syndrome, which is an emergency too.
So in the same way, you can actually have pressure on the spinal cord in the neck. You can have pressure around the nerve roots in the lumbar spine, in the lower back. And that typically presents itself, again, with urinary retention. You're not able to urinate. You have pretty severe pain going down to the legs. It could be one side or the other, or bilateral. And as Doc mentioned, we call it saddle anesthesia. That means there is numbness and tingling in the groin area or in the genital area. Those are all huge red flag signs that there is a severe critical stenosis on the nerves. And when that happens, we typically have about 24 to 48 hours to do a decompression so these symptoms don't become permanent.
Right. So it's important for our listeners to realize that some people think that they could just avoid surgery and it's just an option, but sometimes not having surgery, you're going to be left permanently affected and your life, even paralyzed. So sometimes it's not a choice. You just have to have it in emergency situations. So please, if you are experiencing any of these signs or symptoms, you need to get medical attention right away.
Absolutely.
So that's something that we don't want to wait on because what Dr. Alam had just mentioned about that.
I've heard some docs, may have even been you, use a couch analogy. I don't know if I'm going to butcher it here, but basically like when you put a big couch, like big piece of furniture on a new carpet, right? And if you decide to move that in about a month, carpet's probably going to be fine and perfectly normal underneath. But if you leave it on there for a year and decide I'm going to move it, what happens to the carpet underneath it? That's kind of the same analogy I've been told to what the impact of these injuries can be if you leave them. Sometimes people ask a doctor, what if I do nothing? Will I be okay for a while? And maybe a doctor tells them, yeah, you should be. But it's that concept of what long-term damage are you doing that's irreversible when we try to move the couch or get the roommate out.
Yeah, great analogy. Permanent damage to the spinal cord or spinal nerve.
It's, and I communicate that with my patients as well. Once you lose a function, it's almost impossible to regain it 100%. I mean, we as spine surgeons, we are very aggressive when we see those signs we discussed, balance issues, cervical stenosis or lumbar stenosis. We become very aggressive in terms of our surgical recommendation. At that point, we're not sending the patient to physical therapy or injections. We recommend surgery because we know if we don't do something, these issues become permanent. And, there are studies in spine surgery where they have looked at patients. They have two cohorts. They look at a cohort with cervical stenosis or pressure on the spinal cord that undergoes surgery. They notice that their symptoms stop, the progression of the decline stops, and some patients get improvement. And there's a cohort that refuses to have surgery. And that cohort, because of balance issues, they go to a cane because they feel unsteady. They go to a walker. And again, if at that point there's still a portion of them that have decided not to go through surgery, they end up in a wheelchair. I hate saying that to patients because I don't want to have them choose to have surgery because of fear. But these are factual studies that we have and evidence that we have. I don't expect them to jump into surgery the first time they meet me. And again, 90% of the time, I am not recommending surgery. But if they have any of those signs and symptoms, I want them to understand that, hey, eventually there is going to be a decline. Often they ask, well, how quickly? When is this going to happen? And I tell them, I don't know. If I knew how quickly, or if I knew how to reverse neurologic issues, I tell them I would have a nice boat next to Jeff Bezos. I cannot predict the future.
It's interesting that you you feel uncomfortable, I guess, that you have to explain that to people. But imagine it's such a disservice to not. It's kind of how I'm thinking. I mean, it's almost like, you're not warning them about something that could happen later. They'd be, wait, no one told me that, I would have done it. Yeah. So it's about informing. You can make that choice, but this might be what it looks like.
Exactly.
So it's really important that the doctor.
I just don't want to be the surgeon who, because a lot of times patients come in, they're like, oh, well, this surgeon said if I don't have surgery, I go paralyzed. I don't want to say that because, yes, eventually down the road, but I do go through that explanation. Hey, there will be a steady decline. And of course, once you lose a function, it's very difficult to regain.
And I was actually going to ask you, is there any way to maybe repair any damage that was caused from delaying the surgery? You don't think with maybe modern technology, being involved? I mean,
that's a great question, Jen. There's a lot of research being done on stem cell and PRP,
Right.
in terms of trying to see if we can actually rebuild spinal cord or nerve injury. There has millions of dollars have been dedicated towards this. For example, at University of Miami, there's a project to cure paralysis has been going on for a long time. Unfortunately, there's still nothing concrete and definitive showing that we can actually reverse the symptoms. A lot of times, if there is an issue, if there is a weakness or a numbness or a spinal cord issue, what we do as surgeons is we do our decompression and then we let the nervous system recover on its own. And that may take 12 to 18 months sometimes. So I tell patients to be patient, let things get better and better and better. And again, at about 18 months, I would say, okay, this is it. I don't think it's going to get any better at this point.
Okay.
There's also like a growing practice, it feels like, of people representing to be these non-surgical alternatives.
Yep.
I guess the PRP, the stem cell. I'm curious, what I guess I think you've kind of said your thoughts. It's not quite there yet. It's not ready. But I would say that's another misconception. A lot of people want to explore that or look into it and typically end up coming back to, the spine surgeon route. But they're popping up everywhere, so I'm curious.
I think there is some validity to it. You can probably speak to this as well. When it comes to sports type injuries, when it comes to ligamentous or tendon injuries, there's definitely solid evidence behind PRP treatment, stem cell treatment. The problem with disc and cartilage is that they are avascular environments, meaning that there's not a lot of blood supply getting to that area. So you're injecting these cells that are supposed to grow and become new disc or become new cartilage. Well, if there's no blood supply, there's no oxygen, there's no food, these cells are going to die. So that's been the biggest challenge. I did my fellowship at USC, University of Southern California, with Dr. Wong, and they do a lot of research on stem cell and PRP. And again, even when speaking with them, the lab scientists, they mentioned that, yes, we're working towards it, but we're still not there yet. And that's part of the reason why a lot of insurance companies, or for example, Medicare, doesn't really pay for it. I mean, it's considered still experimental treatment.
Well, you brought up insurance companies. So no, I know I don't want to be a Debbie Downer,
right?
But
something we all deal with.
Yeah, we all deal with
as patients and as providers.
And I know a lot of times insurance companies, whether it's from a car accident or a fall, or you're dealing with Medicare, there's some questions about, well, what caused this injury? And I know that our attorney, Danielle, she hears this all the time. And we have to get an idea. It's hard because sometimes it's very hard to pinpoint, was this fall or accident direct result of this specific injury? But could you speak to that a little bit?
Yeah, so that's a tough one, right? That's the $1 million question, or sometimes more than $1 million question. But so I think we all have. So let me just start with this. We're all at our peak age of disc and cartilage in our early 20s. Guys, I think at age 21, and women at age 22 or 23. From then on, it's a steady decline. Okay, that's why we all get a little shorter over time, because our disc,
That's why, huh? I was wondering,
because our disc and cartilage kind of collapse.
Just all downhill from
some
there.
of their water. So we are all together on this steady degenerative decline, even if we are asymptomatic, right? There are studies that show if you get MRIs of patients over 60 or 65, I can't remember exactly, and these are all asymptomatic patients, over 75% of them have findings on the MRI. Right. When it comes to accidents or trauma, there are a lot of patients who may have degenerative changes on the MRI findings, but they're completely asymptomatic. So, I've had patients who they have been in car accidents. They're, I always ask them. So they're like, since the accident, I've had this neck pain, I've had arm pain, shoulder pain. I ask them, hey, did you have any prior neck or back pain? Is this an exacerbation of a pre-existing condition, or is this a new onset of a new trauma. And if the answer is no, for me, really the direct cause was that car accident or was that slip and fall injury. Again, of course, the MRI will show some degenerative changes. Sometimes we also see some acute findings on the MRI. Obviously fractures are fractures; those are pretty obvious for us. But there are ligamentous injuries that we can see. There are acute disc herniations we can see. We can see inflammation a lot of times on the MRI. I don't want to. Jen probably knows more about this, but I don't want to go in detail.
I'm not a radiologist.
Yeah, on the T2 weighted images on an MRI setting where things are lighting up,
Right.
you can actually say, okay, this is an acute injury. There is, there is an acute ligamentous injury or an acute disc herniation. But for me, it's also clinically, right? You were asymptomatic. Yes, there's some degenerative changes on the MRI, and now you have all your symptoms since the time of the accident. So I do blame the trauma,
Right,
to
and
some
you
extent.
you look at the case history. You look at the person. You do the exam. You're looking at imaging, and then from there, it's a understanding based upon the history, based upon all the factors that are involved in this injury. So it happens all the time, and we want to make sure that we. And then another thing that I feel happens too, and maybe you've experienced this, Danielle, is that people say, "Well, I had back pain 3 years ago, and I don't want to go and I don't want to go to an orthopedist again. This is just like my old injury." So sometimes that happens, and it's not good, because if you have had a prior injury, you have a higher risk of having an exacerbation or making it much worse than what it was. And so I've seen patients that in my clinic that had an accident, and maybe they didn't seek care right away. They were tough and they wanted to tough it out. And a year later, I asked them how it occurred, and I found out in their case history they had an accident. They didn't treat for it, and they had they had some back pain 3-4 years ago, and they just brushed it off because they said, "Well, I had it before, so I didn't really get it rechecked."
Yeah, I mean, causation is just as important as the facts of your case and what we call liability. Any good attorney really should, when taking the case, when first getting the case, not just be working on the facts and the fault situation, but the causation. Meaning, I, for example, will request my clients' entire past probably 5 years of primary care visits if they have it. I want to get as much medical information as I can about you, not necessarily that it'll come up or be used in our case, but I need to know, and the doctors need to know, what your medical history has looked like. Now, it's a little harder when people haven't been to see a doctor, like you talked about.
Right.
Then you, as an attorney, I will say a lot of times we rely on, what they've told the doctors and affidavits about, their sworn testimony about what their life has been like before this crash. But in general, I prefer a case where someone has a prior injury. That is an easier case every single day. Why? Because they have gone to see someone for that. We have something that we can compare from before to now. Alternatively, we just have my client's word that it's never bothered them before and they've never complained about it. But when you're able to directly compare prior imaging, for example, to new imaging, huge causation, proof right there. But even if it's, looks similar, like he said, you can rely on the client's experience. What does it feel like? Yes, I had this in my MRI, but as you can see from all of my primary care visits, it wasn't something I'm mentioning. I wasn't going to a chiropractor. I wasn't doing anything, go for checkups, and I'm not mentioning anything about this. It's a big misconception that attorneys will turn away a case if someone has a prior injury, and I think that's very much wrong. But it's about not just having that person go to a doctor blind without them knowing about all of this information. So that needs to be shared. Medical records need to get shared. A whole complete picture of that person's history, obviously, so that when they are finding that this is acute, it's supported.
Yeah. Yeah, I've had patients, exactly what we're talking about. They said, "Oh, this was from 3 years ago, my back pain, and maybe their chief complaint might be neck pain. They do have back pain, but they're like, oh, don't worry about the back pain. We don't have to really focus on that. This is from a football injury, or this is from something else. And I need to write it down. I need to do an evaluation because, again, the condition could have been made worse. So that's, I think, a common misconception.
And I'd just add to that, Florida law says you take your plaintiff, you take your person as you find them. So if you hit someone who maybe it wasn't the biggest crash, maybe it was a low impact, and the insurance company will always remind us, there's no damage, you can barely see anything, but that person is the one who's had this long-standing back injury and their back was already somewhat unstable, you're going to cause a lot more damage to that person than you are to the average person. So this comes into play a lot when they're bringing up things like the impact, for example, the force of impact, or how could you expect to see this kind of injury from this type of fall? Well, when the person is, their spine is in the condition that it was when Mr. Jones was walking on this sidewalk, it's not the same as a healthy young 15, 20-year-old doing that.
Right. And I think what we had talked about before, people in their 40s, 50s, 60s, they could be relatively healthy, but they're going to have some degeneration. And if they get in the same car accident that somebody got into that was 20 and really healthy, chances are the person that is in their 50s and 60s, if all things being the same, will be affected differently and have different pathology than the younger person. So I stress a lot to my patients, if they have another accident, or if they're a parent or somebody that's older or had other issues or complaints, to get checked, even if they think, well, it's only a little bit, because sometimes it could be something subtle, but it might really need to be checked out because it's a risk factor. It could be complicated and worse.
So to your guys' point, obviously I agree with everything. I feel like there is a threshold, there is a line, right? So, you can have all sorts of symptoms, all sorts of injuries, a basketball injury or a football injury, and it comes and goes and waves. There is an additive effect of these injuries. Once you cross that line, and now your body's actually manifesting pain. Otherwise, your body was compensating for a lot of these issues. Now you have crossed that threshold. Now you're going to have these symptoms. I sometimes look at an MRI and I look at the patient's age on the paper, and I see that the MRI looks much older than the patient.
Really?
And I know, and this is before I walk in the patient's room, I get a 32-year-old patient, and I look at the MRI, I'm like, is this the right patient? I keep looking at the name. I keep looking at the date of birth. It is the right patient. And a lot of those people, before I go in the room, I tell my resident or my medical student, I say, I promise you they have a pretty physical job, or they're either former athletes, football players, D1 athletes, or military guys. They really, really have beat up their body. So there is an additive effect of these issues and injuries. So, you're basically at that threshold, and you get in a bad accident, and here you are manifesting with all the symptoms.
Right, like the compounding effect.
Right.
It works for investments, but it could also work to our detriment with spinal injuries and wear and tear on the body.
I work with a lot of law enforcement officers as my clients, and Doc knows he's treated some of them, but that L5S1 from that duty belt,
Right.
Yeah.
I think I've never seen a clean one on an MRI. I've never seen an uninjured lower lumbar level, because they wear the belt all day, but what matters is, was it something they were seeing a doctor about? Was it something that they were complaining about? Was it affecting their quality of life?
Right.
But that's why I'm a big proponent of imaging. Even if you
Absolutely.
feel absolutely fine. I was 18, I was in a crash, too young to care, too young to do anything about it, and had to deal with it myself when I was in my 30s. So I am a big proponent that just like you check your car after an accident, you take it in and get it checked under the hood, you got to do the same thing with your body.
Definitely.
Especially
MRI
before you
is
settle the
definitely crucial for diagnosing and treatment.
Yeah.
I mean, with the patient, because if you don't know what's going on, how are you going to help them? How are you going to help them get better?
No.
So MRI is definitely crucial.
100%. So and we live in a day and age where patients want to know. I have to mention this, that when you look at recommendations from the American College of Physicians or the North American Spine Society, all these academic institutions, what they say is that if there are no red flags,
Right.
don't get an MRI. Don't jump into an MRI. And a lot of insurance companies, unfortunately, don't approve an MRI. But from my personal opinion and recommendation is, if we can get an MRI, at least we know we have a baseline. We know
Right.
what's going on, and I think the treatment is going to be more specific and directed. If you're going to see if you're having chiro treatment or physical therapy, then that provider knows what specific injuries they're dealing with, as opposed to, my back hurts. There's so many different sources that could be
Right.
contributing to it, and without having advanced imaging, it's difficult to address it.
I definitely wanted to touch into AI imaging and surgical too.
Yeah.
Because now with AI and imaging kind of like, merging, and with the surgical, I know you're doing a lot of stuff with robotics and like surgery. But with us, like we're seeing now, like the imaging is going very quickly, like the scans are speeding up. Imaging now is like more like we can see like more adequate, like more clearer images. So I just wanted to know like your take now with AI merging with surgical procedures and techniques, and how is that helping and influence the way that you're going about with your procedures and operating?
So that's a great question, Jen. So in my practice, I do rely on robotic surgery. I do robotic spine surgery. What we know is that using robotics helps us improve accuracy, reduces our incision sizes, and as we discussed previously, that it translates into a quicker recovery because patients have less pain, less wound issues, less length of hospital stay. So those are the advances that we have with robotic spine surgery nowadays. As far as AI goes, that's also making its way into medicine, as we all know, especially when it comes to radiology, because the AI software is picking up all the pixels and picking up all the images and comparing it to a massive database and saying, hey, this looks like a disc herniation at L5S1. This patient has a disc herniation at L5S1. And I would say they're still not as accurate as a board-certified radiologist
Exactly, yeah.
reading it.
And also there's the legality factor in there, and the moral ethics too. I mean,
Right. There's so many questions
Yeah.
when it comes to AI. As far as spine surgery
Right.
goes, a lot of spine companies are actually looking at implementing AI to help with your surgical recommendation. So part of the reason I went to spine surgery is because I felt like that there's not one right answer for the same problem. Not everything is black and white. You
Right.
could have 10 spine surgeons in the same room, show them one patient, you can get 10 different answers. With AI, at least you have some help saying that, hey, Miss Jones, who is 65, who has osteopenia, who has, that's her diet, this is her routine, her symptoms are back pain and some leg pain. This is the smallest surgery that we recommend. Obviously, as a surgeon, you can, make up your own mind and have that information to help you with the process. But at least it's putting all that data together and saying, hey, there are other patients with these characteristics
right.
that have had this surgery, and this is how their outcome is, and this is the best treatment for them.
Right.
So that's where AI is coming into spine surgery.
Amazing. So fun fact Friday. So you were featured in GQ.
Okay.
Yeah, you did a GQ article.
Yeah.
Which I did find fascinating, and I'd like you to kind of enlighten us. I know that you had mentioned, Benson Boone. He's
Yeah.
a pop star singer, and he likes to do all these backflips. He was on Jimmy Fallon, flipping over couches and all
Yeah.
that. And he's like, well, I was doing this since I was 5, so it's not really affecting me.
Right.
And you had some words to say about that.
Yeah, so I was lucky to be interviewed about him
Right.
in GQ magazine. My picture wasn't in it. I wasn't cute enough for GQ magazine. But yeah, it was about the effects of backflip on potential back
Right.
injury. And Benson Boone, I mean, he's pretty much an athlete. I mean, he has a very strong core, so he will not hurt himself. But if I would say any of us
Right, yeah.
try to do his backflips, we'll probably hurt ourselves. Repetitive trauma to the lower back, especially at L5S1, with that hyperextension type maneuver, can lead to what we call a pars fracture. It's a fracture of the kind of a bottom level at the the bone that connects one level to another level. And it happens typically in younger patients, a lot of gymnasts, linebackers, divers, and that typically happens in them. A lot of times can go unnoticed. And then later down the road, to your point, if it's gone untreated, this will come back, and it will come back, and it becomes an issue. I've had patients who in their 50s, 60s, or 70s, they come and see me. By then, the fracture, which has never healed, has led to a slippage of one level over another. And now I tell them, hey, this is an old fracture that you had. They're like, I don't remember this. So, So that's basically what that GQ article was about. It's like repetitive movements can lead to a fracture like that. But I think Benson Boone is basically an athlete,
Yeah.
I was trying to say,
Absolutely.
don't try this at home, basically.
Yeah, don't try
Exactly.
this at home. Yes.
So for our people listening out there, what are some tips that you can give so people don't wind up in your office or another spine surgeon's office? Because we want to help the listeners, the people viewing these videos. What are some tips you could recommend? I mean, there's some things you just can't, because you could be at the wrong place at the right time and get hit by a car.
Right.
Number one, don't
but-
get hit by a car.
Exactly.
by a
Don't
car,
get hit
yeah.
by a car.
Yeah. It's spine care. I would say just live a healthy lifestyle. And that is not only having a good diet, but also exercising routinely. I recommend lower impact exercise, where, focusing on core strengthening. So yoga, Pilates, swimming, those are very good, great exercises. The stronger the core muscles are, abdominal muscles, your oblique muscles, lower back muscles, or even the muscles around your neck, the less pressure on these poor joints, right? So help these guys.
Okay.
Not putting on too much weight. And again, having a healthy diet, I think is the way to go. Those are the modifiable risk factors. Unfortunately, we have all been given a Delta set of cards called genes, and, we cannot really change that. A lot of patients ask, well, why did this happen? I say, well, it's just wear and tear. And also, do you have parents or grandparents? Yeah, my mom had surgery. Yeah, my grandparents had surgery. There is a genetic predisposition to a lot of these issues as well.
Okay. And after spine surgery, what are some things that patients should not do? Maybe they didn't remember what the surgeon said, and there's somebody out there that had surgery. What are things they should not do?
Well, I would say it depends on the type of surgery that they have. I would say be very compliant with the post-operative protocols that your surgeon provides, depending on the type of surgery you have. Even if you're feeling good, if the surgeon tells you no golf for 3 to 6 months, please no golf for 3 to 6 months.
Why do men have such a hard time with
I know.
that?
Yeah, I've had patients who are doing great, and they're at their 2 months. They're like, Doc, I'm installing a golf stimulator in my garage. I'm like, what?
And you're like, no.
I'm like, what are you talking about? Why now?
Yeah.
Well, I mean, you
Right.
just had spine surgery. With spine surgery, unfortunately or fortunately, we have to be patient. A lot of times it takes a few months to get better. And even if you're feeling better, I tell them, hey, things haven't fully healed. Things plateau and get as good as they get at about 9 to 12 months after having a spine procedure. So I tell them to be patient. And again, different surgeries have
Right.
different post-operative protocols. Just be compliant with the recommendations.
Okay, great. Well, we have a little ritual towards the end of our show that we do, and we give new guests that come on a superhero tumbler, and they're right up over here, and they symbolize comeback, resiliency. And I'm going to have Dr. Alam and Danielle each pick one out. And if you can, speak to a little bit of why you picked the superhero tumbler that you did. So, yeah, Dr. Alam, yeah.
Oh,
I obviously have to choose Wonder Woman.
Wonder Woman.
Because she's the only woman
They're
up
matching.
there. But
That's the
I
one
will
I
say
wanted. Come
the
on.
meaning, the meaning apparently is compassion, inner strength, and fighting for justice, which is my
Yep.
motto.
That is
So I feel like I've made the right choice here.
Yeah,
Right.
I
Hey, look,
think
we're twinning.
And Danielle, how could people reach you if they want to talk more about an injury?
Sure, yeah. Well, yeah, absolutely happy to help with any injury that you've suffered due to someone else's negligence. You can contact me at Kushel Law Group, follow us on Instagram and all social media, Your Family's Injury Attorney. Check out all our videos and our information on there. But we also do free auto insurance audits. So you send it to me. You don't even need to have much of a conversation about it. You just upload it, and then you get back from me a comprehensive analysis of what your personal auto policy has on it, just for you to have, so that when you meet with an agent or try to buy a new policy, you know what you have been purchasing, and maybe to spot some gaps that you haven't covered in your insurance.
Great.
So check it out on our website.
We'll have Danielle's information in our show notes. And Dr. Alam, which Tumblr are you picking?
I have to pick Batman.
Oh, nice.
Nice,
I
Batman.
like it. I like
Well,
it.
first of all, he always drives the coolest car.
Right?
You know?
He goes to parties.
All right.
Yeah.
He's awesome. And yeah, you know, he's quiet but deadly, and you know, he's disciplined. He overcomes challenges by just being quiet and persistent. And
He's
I
a
like
pain healer.
Yes.
Which
He is.
You are.
Yes.
Yes, they all are in
Right.
some ways.
And if people want to contact you or come in for an appointment, how should they reach you?
So I'm lucky to work with a great group of colleagues in a group called Florida Spine Associates. We have about 5 offices throughout Palm Beach County, all the way from Fort Lauderdale to West Palm. Our website is floridaspineassociates.com. One of the nice features of my practice on our website is that you can actually upload your MRI images on our website through an app called My Medical Imaging. And even if you have difficulty with that, there's about 80 CVS stores that help you upload in Florida. They can help you upload your images, and then we can have a telemedicine appointment, even if you don't live in the vicinity of one of our offices.
Great. Okay. Awesome. And Jen, thank you so much. And she is a representative for Windsor Imaging, excellent MRI center throughout South Florida.
That's right. We have 3 locations. We're in Delray, Fort Lauderdale, and Fort Pierce. We're an open MRI. We're claustrophobic friendly. We provide transportation, great quality images, as
quality.
you can attest
Yep,
to.
yep.
And if you guys ever
Phenomenal
need
customer service.
Thank you. And if you guys ever need an MRI, please feel free to reach out to me, Windsor Imaging, or you can follow me at your MRI Girl on Instagram. I'm available.
I can attest to it because
Yes, you
I've had
can.
my parents
Oh,
have their
right,
MRIs
your mom.
at her
Yes.
imaging center, and they were so happy and
That's
pleased.
right.
Yeah.
Yes.
Thank you.
You're welcome. Yes.
Awesome. So you are not alone out there. With a good team, with more information, being prepared, you can make a better decision and not feel so afraid of making these important decisions. Thank you for tuning in today. And please, if you have any questions or comments, make a comment below and we'll get back to you. And like I say all the time, share, like, follow, subscribe. See you on the other side.
Thank you, guys.
Thank you.